Good morning, everyone, and thank you for joining us today. We welcome you to the Accelerating Integrated Care series. We're delighted you're all here to join us today, and we look forward to sharing and discussing the importance of measuring, screening, and access for behavioral health. Today's webinar will feature members from the Pacific Business Group on Health's Patient Assessment Survey team, as well as the California Quality Collaborative Program. As a reminder, this session is being recorded and we'll be sending the presentation slides, the recording, as well as any other resources mentioned via email to registrants later this week. Before we get started, I know we're all pretty familiar with Zoom, but the next slide shows a couple of Zoom tips. Just as a reminder, everyone is muted on entry. And if you're having any technical issues, please direct your chat messages to me, Michelle Ma, and I'll do my best to assist you. And throughout the webinar, if you have any questions or comments, please utilize the chat box and we will moderate and answer as best as we can. We're going to start with a poll. So we just would like to see where everyone is from where they're dialing. So we'll get this launched. You can let us know from where you're dialing. That's the first question. And when you vote, remember to click the submit button to complete the poll so that your answer is submitted. And there's also a second question. What type of organization do you represent? We just like to get a sense of where everybody is. So we'll give everybody a couple of minutes to fill that out. And also, once you're done voting, if you could chat in your name and organization into the chat box, that'd be appreciated as well. So everybody can still fill in their votes. We'll give a couple more seconds. Great, we've got a good variety of people, it looks like. Thank you for joining, everybody. It's great to see you all here.
Can you share the results on that?
Sure.
Or did I miss it?
All right. Does everybody see those results now?
Oh, so we have a lot of California represented here, and Bay Area a lot, and hello to our friends in Inland Empire and Southern California in there, and outside of California. Awesome. We have some new people joining us. Welcome. And I see that we have a lot of people representing provider organizations, and that's great. And so our IPAs, our community health centers, our medical groups. And thanks for joining us.
Yeah, thanks everybody. Glad you're here. Okay, and for those unfamiliar with CQC, here's a little bit about us. We're a healthcare improvement program. You can read about us on the slide. I won't go too much into details, but if you'd like to know more about us, you can visit our website, calquality.org. And you can also find more info about our parent company, Pacific Business Group on Health, at pbgh.org. But once again, thank you for joining us. And at this time, I'd like to turn it over to Crystal.
Hi, welcome everyone. I am Crystal Eubanks. I am at Pacific Business Group on Health and work on our care redesign team and our California Quality Collaborative. And so I'm the Director of Care Redesign Strategy and Programs, but I've been around a while and have a long history of working in primary care, and a particular passion of mine is integrating behavioral health. And so this is an aim of our work for several years, and is to bring the insights, right, highlights new emerging evidence about how to effectively integrate behavioral health into primary care to you guys and lift that up. And I am so happy today to finally get to share the virtual stage with a colleague of mine Emily London of Pacific Business Group on Health. And she's on our team. While I'm on the care redesign team, she is on a team that does measurement and accountability. And so it really works to get data out there, make it transparent, and make it really usable. So we try to work synergistically. But she also has been leading the charge on a patient assessment survey, which is a I think national tool at this point to collect patient experience data, and she's going to share more about what the tool is and how it's used. So she's going to share those insights. So today we're really going to dive into a topic that I'm going to say is a very large topic and more than one webinar. But today we're really going to focus on, let's look at what is kind of the current state of access to behavioral health screening and treatment, particularly in California, but I think those numbers represent what's going on nationally to varying degrees, but close. And we're really going to think about, of all the different data sources to really measure access and screening, how might we use patient-reported access and experience data, right? It's not something we traditionally use. And then what actions might your organization take using this large data set that Emily's going to share, or even to start to collect that information amongst your own patient population or your members. So we'll dive in. I want to say this is a big topic, and I say thank you to everyone for in your registration. You guys teed up a ton of questions we looked at, and I very much enjoyed seeing them. And there's so many questions there about behavioral health screening and treatment and care coordination and this just huge bucket of work. And so we're going to try to break it into bite-size nuggets where we can get a little deeper and not try to touch on everything. So we intentionally started today with how do we measure? And I'm with the California Quality Collaborative. I would be remiss if I didn't highlight the model for improvement and really say, so when we think about setting the stage for our discussions here is like, let's talk about how will we know that a change is improvement, right? This is our measures and what we look at. And in subsequent webinars, we'll really get into what are the changes we can make? How can you actually move the numbers? So today focused on kind of measurement and just better understanding our problem so that the changes that we choose, right, are gonna be more effective in solving that problem. So on that note, I just want to highlight all the different questions that came in, and these, thank you again, they're incredibly valuable to kind of shape further webinars in our series. So, so I think there's a webinar that's coming up of understanding the measurements and screening tools. There was a lot of questions about, specifications, what are the different measures, and so I think there's an opportunity to really highlight and dig into that, especially as more people start using them, as well as the different screening tools that are out there quite a bit. There was a lot of questions about improving access to behavioral health screening, which is ultimately one of our goals, and really digging into what are the barriers that clinicians are facing. So I think that is a webinar topic all in itself. Could be several, but a future one that will be in a follow-up to this one, as well as even improve screening, right? We're going to identify a lot of people. So how do we actually really get them access to treatment and care and improve outcomes, our ultimate goal. So thank you for those questions. Okay, the current state. And I'm highlighting things that you guys came to this webinar, you're probably already very interested in this and working in it. So I'm not necessarily sharing news. So I just want to frame kind of the data that's coming up that Emily will share, right? And so thinking about the incidence of mental illness, I think these numbers are a bit old and actually before the guidelines came out about screening annually for depression, right? And so these were like 15% of California population. And I think the most current numbers at national is about 20%, right? This is from NAMI, National Association for Mental Illness. Anyway, I'm bad on the acronyms, but they have some really current data that's nationwide, but not state specific. That's 20% of our adults are dealing with some kind of mental illness, right? Not just serious, but on the entire spectrum of what it is. And some questions came up about what are the evidence around screening for depression. Tried to dig into it, but I put a link here on the bottom of these slides, and when you get these, and we can figure out how to get that into the chat box, that actually summarizes all the evidence out there, but there's strong evidence, right? Hence the guidelines for clinicians to be screening adults every year for depression. So we also think about treatment. So there are people known, right, that either diagnoses that have been screened or presented in some way. But then we think about how many of those people actually get treatment. And we're still challenged. While I think it's improving, we're still challenged with the majority of people are not receiving the mental health services that they need. So this is kind of our starting off point for this conversation. Then we have this year and all the things, the monthly calamities that are happening. And so we think about what, we already know, but, coming into this year, the access to screening and treatment are a challenge. And not enough people are getting that. And then we have just the increased impacts of particularly the pandemic, but everything going on. And so the Kaiser family has been doing a survey nationally of patients and just saw from March to July of 32% going up to 53% of adults reporting that their mental health has been negatively impacted due to worry and stress over the coronavirus, not to mention everything else. So we know that there's this increasing demand, right? And we're hearing it from providers. We're hearing it from health plans, right? I've heard anecdotally some health plans say anxiety claims for anxiety or diagnoses went up 30%. And so there's even more demand, right, that's coming. And that's coming through our primary care providers and those practices, right? Being the front lines and often the first, most frequent and most trusted entry point into care, right? And so they are hearing about and seeing this in their patients and starting to where there was, yes, we should do more screening and we should treat this in primary care, but it's hard to add on to everything else. Well, that was kind of the mood, I would say, last year. This year, primary care practices we have to deal with it. It's just coming in, it's on top of everything else, and we can't not, so please help us. So that's kind of the nature of what's going on within, particularly within California, as the practices I've been in touch with, but I'm hearing that from our partners in other states as well, some even more so. Right, so another data point of looking at the symptoms of anxiety and depressive disorder, weekly data, and just kind of inching up. Yeah, so it's there. So we asked you guys in the registration to tell us about how you're measuring behavioral health access. And right, I think I wouldn't say it's an emerging field, but there's lots of ways to look at data to try to get a sense of what's going on. Right, and I always say really good data doesn't necessarily answer the question you've asked, but it helps you ask more insightful, deeper questions to start to get more information to shape that. So you guys, I kind of put this in a little pyramid shape of most people answered that they were using standardized clinical tools, right? Our PHQs, our GAD-7s. So using this within clinical care and monitoring the, right, that coming out of the EHR, basically, their electronic health records. And then a number of people admitted that they were using a combination of the standardized tools. So that's pretty cool too. So to have more of a comprehensive assessment. And then others are looking at the measures being calculated, right? I think this is probably maybe our health plan folks or other ones, those performance measures. A good chunk of people actually didn't know, so they had to go find out, or they weren't measuring it at all, which is totally fair. Some appointment availability, and then a few patient surveys, which we'll highlight today, and then a peer review. So lots of different ways to measure patient access. So today we're going to look at what are patients across California reporting, and so I'm going to give a little background to. I think it's been a year in the works of collecting data, but the Patient Assessment Survey and CQC came together to create some questions around behavioral health screening and treatment from the patient perspective, and pilot these questions in their survey that they fielded in the past year. So I want to say a big thank you to Melora Simon, who was very much involved in leading this and making it happen, and then her work more broadly in the field of behavioral health integration. And then thank the team, the committee. There's a PAS committee that's helped do this. And so this is kind of the culmination of us getting to work together and share this. Selfishly, I wanted to know the data to help guide our work, right? And to analyze and say what's going on in different parts of California and all this. But I think it's such an important tool for provider organizations to have and to use. And so later in the session, Emily will dive into how you can actually use some of this data. So I'm gonna hand it to Emily London. Welcome.
Hey, thanks everybody, and thank you, Crystal, for that overly kind introduction. I hope I live up to your expectations here. So I will sort of go through a little bit of background about patient experience for those of you who are probably and hopefully not as wonky as us internally at PBGH, why it's important. Then we'll go through the research that we did, and then I will share the results, and then we'll talk about how you can apply those results to improve quality within your own organizations. So first, why patient experience in the first place? I know some people think this might be a somewhat fluffy term, you know, it's just about availability of parking or how nice the building was. I have to say that's not the case. It is a very important quality indicator. Of course, there are many different ways to measure quality, but it's really important to measure patient experience. Research has shown that patients served at organizations that prioritize patient experience and have better patient experience have better outcomes, better quality of life, they're better able to manage their diseases, they adhere to treatment and medications more often, they get their preventive screening, and also they use less resources. So it's a very important quality indicator. And as you'll see on the next slide, patient experience is also very, oh, one back. Oh, it's not there. Okay, well anyways, I'll just tell you verbally. Patient experience is also really important to business. So there is a financial reason to prioritize patient experience. Provider organizations that have better patient experience have higher employee satisfaction, better patient loyalty, and also lower risk of medical malpractice claims. So two different really important reasons to prioritize patient experience. So patient experience, we at PBGH manage the nation's largest patient experience program in the country. I'm very proud to say that. Of course, there are many, but we are the largest multi-stakeholder nonprofit program. Every year, we gather feedback from over 40,000 patients across 176 medical groups in California. And the program is supported by 11 health plans. And most of our work is measuring patient experience at the medical group level for HMO and POS patients. We also have a somewhat new program in the last few years to measure patient experience for Medi-Cal patients as well. So a fun fact that I'm also very proud of is PBGH back in the early 2000s actually set the precedent for developing the gold standard CG CAPS instrument that is used nationwide to measure patient experience at the medical group level. So very thrilled. We are vanguards in this field, and we continue to be leaders in the patient experience measurement field. And the CG CAPS stands for Consumer Assessment of Healthcare Provider Systems, Clinician and Group Survey. Acronyms, I tell you, there's so many of them. So we use the CG CAPS as the basis for our annual survey program. We measure 5 domains of care that have been identified as the most important to patients. Those include access, was I able to get an appointment when I needed one, communication, care coordination, office staff, and overall ratings of care and provider. So why did we do this research? We know that access is a struggle for patients suffering from mental health conditions, both in California and nationwide. As Crystal mentioned, a lot of people, up to 20 to 25% even of adults, suffer from a mental health condition, yet more than half do not get the treatment they need for multiple reasons. And of course, I'm sure, as Crystal said, if you're on this webinar, you probably know these already, but barriers include access, cost, and stigma. And one of the key barriers is the low availability of mental health care providers that take insurance. And that's at about 50%. And external research has shown that that is much lower than for other medical specialties. So there are a bunch of different reasons why this is a challenge for folks. And as they say, if you don't measure it, you can't improve it. So we wanted to get more granular data. There are statewide rankings on mental health in terms of access and a whole bunch of different criteria, but there isn't much data available both from the patient's perspective and also at a more granular level than statewide, even though we know that there are different areas across California, especially, that have workforce shortages. So there are likely regional variations. And it's really important to get the patient's perspective because a lot of the measures that are used for these state rankings are more process-oriented measures. Were patients able to get an appointment? Was a screening entered into an electronic medical record? But we really don't know how the patient is experiencing this care. If they felt like someone was discussing their mental health symptoms with them in a way that was meaningful, and if the patient was able to get an appointment when they needed one, not just were they able to get an appointment. So that's really why we did this research. So I am also proud to say, I'm going to keep saying that because I think this is a really cool work that we've done. We were able to collect data from 35,000 patients in California. And a friendly reminder, these are mostly HMO patients, some Medi-Cal as well. And as Crystal mentioned, we added the research questions at the end of our annual statewide survey, which is how we were able to collect such a large amount of data. And again, just another big thank you to Melora Simon and Rachel Brody, who were on the call, for helping to lead this work. We actually spent 2 years working on this. We spent a full year developing the research questions because we did a nationwide scan of available research questions to measure mental health screening and access. And while we liked what we found, it wasn't quite a fit for our statewide survey. So we actually worked with a really dedicated volunteer group of behavioral health experts across multiple different settings to develop our own questions. And then we spent a full year fielding these questions with patients. So we're very proud of that. And just some background information on the PAS survey so you can better understand who received the survey. The survey does go to patients who saw a primary care provider or a specialist. The sample is actually split evenly between the two. But one important thing to note is that this survey was not sent to patients who had a behavioral health encounter. That's just the way that the survey is set up. I think it would be really interesting to field our questions with patients who had behavioral health encounters to see how the data differs, but it's what we had available, so it's what we worked with. And the survey does ask the patient about their experience over the prior 6 months. So what did we measure? I will share 2 main buckets of information today. And of course, we have more granular detail that we're not going to bore you to tears with today, but we will be publishing an issue brief that will go into more detail about the research that we did. So we really wanted to find out about screening rates and access to mental health care services. And we did create 2 separate buckets of questions, one for physical health care and one specifically for mental health care, because we wanted to compare and contrast access to mental health care versus more standard physical health care. And we do realize this is an artificial dichotomy we've created, but for research purposes, we thought it was important to compare and contrast. So we did ask for screening on mental health. Did someone ask you about your mental health care symptoms? Did they recommend treatment? Did you feel like you needed this treatment? Were you able to get the care you needed? And were you able to get the care you needed when you needed it? So just a visual of the flow of the questions we asked. The first question in the question set was, did someone from this provider's office ask you about your mental health? And that was the anchor question, because we felt like it was really important to better understand if screening is actually taking place in a primary care and specialty care setting. And then we asked the patients, if not, no one asked me, then to not answer the rest of the questions, just skip to the very end of the survey. If they said someone did ask me at the provider's office, then we asked a follow-up question, was treatment recommended? And I do want to qualify that when I say screening, we didn't ask, did someone ask you to fill out a PHQ-9? Because first of all, we weren't sure that patients would really, understand how to define what a mental health care screening looks like, and we wanted to be more broad to capture a wide range of experiences. So we did say, did someone from this provider's office ask you about a period of time where you felt sad, empty, depressed, or anxious? wanted to capture a broad range of experiences. And then was treatment recommended? We didn't want to narrow it down too much because we weren't asking about one particular condition. So we did ask, was help recommended? So it wasn't like, did someone from this provider's office send you away to a facility for substance use disorder treatment? Wanted to keep it more general. And then if treatment was recommended, did the patient feel like they needed treatment? We thought that was important to ask. And then if treatment was needed, was the patient able to get it? And were they able to get treatment when they needed it? So those are the questions we can answer, and I'll share the results with you now. So the first question, how many patients were screened for mental health symptoms? We weren't very surprised to see that only 33% of patients said someone from their provider's office asked them about their mental health. And if someone from the provider's office did ask about the mental health, we wanted to know how many patients said their provider recommended some sort of assistance for mental health symptoms. And that was about half, which we were actually very surprised by. And one thing to note, it's unclear if patients who had treatment recommended just remembered that they were asked, or if you do screen your patients, half of them are going to need treatment. I would imagine it's a combination of both. And if patients needed treatment, we'll say, I did skip one thing, how many patients actually felt like they needed treatment if it was recommended? Actually, 2/3 of patients agreed, yes, I did need the treatment that was recommended for me. And if they needed care, how many patients were able to access it? Actually, 60% said that they were always able to get the care that they needed for mental health, which I was surprised by. And if they needed care, did they feel like they were able to get it when they needed it? And again, this is the benefit of asking the patient, because you don't necessarily get this from processed data. And 57% said they were always able to get care for mental health needs when they needed it, which again, I thought was rather high, higher than we were expecting at least. So since we did start the question set asking the patient, did someone from this provider's office ask you about your mental health? If yes, continue the rest of the questions. We also wanted to better understand, well, how many patients either needed care or accessed care, but said that no one from the provider's office checked in on them. And it was actually a fairly high number. We really noticed this as we were digging into the data. A lot of people said, yes, I got care, but no one asked me about it. So 16% said that they needed treatment, but no one asked them at the provider's office. 29% said they got care on their own, but no one from the provider's office asked them about it. And 35% said they were able to get timely care, but no one asked them about it at the provider's office. And of course, we don't know the details from the research we did about why this is taking place. It might be appropriate that the provider didn't ask, but we would like to think that the provider is checking in on the patient and also understanding where the patient is going to get their care so that they can coordinate the care better. So takeaway here, screening is important. So this was the most surprising finding of our research. We had two hypotheses. The first one was that access to mental health care services would be lower than for physical health care services. And we also thought that access to timely care would be much lower for mental health than for physical health. And the first time, I'm happy to say in my life, that something failed. Both of our hypotheses actually failed. That was not the case. We looked at physical health and mental health separately and access for both. And there was actually no significant difference in access to appointments between mental health care and physical health care. And timely access was actually slightly higher for mental health care than for physical health care. And I do want to caveat a few things with that finding. As I mentioned earlier, the survey was not sent to patients who had a specific behavioral health encounter. So there's a chance that the results might be different if we had asked those patients. And also, of course, the incidence of behavioral health care needs is lower than in general than for physical health care needs. So it is a smaller sample size for the mental health care question answers, but interesting nonetheless. So we also wanted to dig a little deeper just because we do have this huge data set available. And during registration for the annual survey, we asked the provider organizations to self-identify their group as an IPA or a medical group. And we took a quick look at any differences in our research questions between those two types of organizations. And you'll see that actually screening rates at IPAs were almost 9 to 10% lower than at medical groups. So a key takeaway is if you are at an IPA, this is probably something you're going to want to focus on. Interestingly enough, there wasn't a lot of difference in access either to overall appointments or to timely care between IPAs and medical groups. Just an interesting finding. We also looked at differences between Northern California and Southern California. And we do this because we've been checking this data for maybe 10 years now across the regular PAS results, because Northern California provider organizations tend to perform slightly better on a good chunk of the PAS composites than the Southern California groups. Again, we don't know why this is, but we thought it would be interesting to look at the results for our research questions. And there actually wasn't much difference at all, as you can see. And one thing to note is we are going to be doing a further analysis and looking at urban versus rural scores on the screening and access questions. And we will be publishing those findings in that issue brief I mentioned earlier. That will come out sometime in the future. So to summarize, there were many findings that were both in the expected category and very surprising category. And later on, we'll actually get your thoughts on that as well. So what we found that we expected screening for mental health needs would be relatively low, and that turned out to be the case at about 33% being screened. Access to care overall was low across the board. That's just something we've seen in our overall PAS data, so that wasn't super surprising. And also access to timely care was low for both mental and physical health. But what was really surprising, and again, why we do research, we just love to learn these things, of those asked about their mental health symptoms, half had treatment recommended. That was surprisingly high, at least to me. And as I mentioned earlier, there could be several different reasons for that, but I think it's just something to note and really underscores the importance of screening to catch everyone who does need help, because there's a good chance that people who are asked about it are going to be struggling, especially as Crystal mentioned during the pandemic right now. It's especially important. And our two hypotheses that both failed, there was no significant difference in access, both to overall appointments or for timely care between mental health and physical health. So those were actually the core findings, and I'll turn it back to you, Crystal. Or Michelle.
So we thought we'd give you a moment to process these, and if you guys have questions, and I see some already coming in, go ahead and put those in the chat box, and we'll tee those up for Emily. But while you're thinking about that, so we wanted to do an activity to get your perspectives on some of these surprising findings, or what wasn't surprising. So we're going to do some annotations, kind of like dot voting that you would do in person, but we're going to try it virtually. And here are some instructions. We'll give you a little test run. So at the top of your screen, you'll see the view options, and you can click on annotate. So also when I top of my screen, right, it has next to like sharing, there's a little pencil that says annotate. And if you click on that, you click an options will come up here, this kind of second row of a stamp, and then you can select a stamp, and then you can hover on the screen, put your mouse over it, and put a stamp there. So Christina just put one there. So I'm gonna ask you, everyone, just give this a try. We'll give it a few seconds. I see Janetta got a heart, Carrie Ann, Lance, yeah, okay. People getting this down. I get to see who else here. Yeah, so give that a test. You feeling good? Okay, got some more coming in.
I think Danielle likes to color outside the box.
Okay, so we're gonna put a pause, and I am gonna clear this. Did that work? Oh, wait, let me see. Oh, Michelle helped me, thank you. So now we're gonna do this based on the content and the findings that Emily shared. So using your stamp, excuse me, let me go back real quick. Then you are gonna click on the one that might be most interesting, most useful, something your organization might wanna dig into. So you'll just click in that white space. Yes, so we have one check. So someone's finding it very interesting. Access to care is low for both mental and physical. So something worth confirming in your own organization. And feel free to do multiple. This is not a single choice answer, I should have said. And I'm hoping as you guys do this, right, and give it, this is like feedback of maybe there's further places that we want to dig deeper, right, in this big data set. Okay, so it's looking like most people really want to dig in about if they're screening, then many patients have treatment recommended. And so this seems to be a high rate of that they need care, right? And I'm going to pause it and you guys can check me. I know Lance will, but right, if, so as we increase screening, right, are we going to see more and more demand for services? And we have to think about access to the care that's there and our systems to shore that up, right? And then kind of our second place, right, access to care is low for both mental and physical health. Yeah, I think checking that was surprising for me. I think surprising for a lot of people. So I think checking that within our own organizations and how we might do that with our own data. And then access to care is similar for mental and physical health. Yeah. So clarifying, right? Low across the board. Right? So this is not that access is that mental health care access is high. It's low across the board, but it is not maybe as horrible as we thought. I don't know. Okay. Well, thank you guys so much. So we're going to clear that screen. Michelle, if you can help me with that. I'm going to stop sharing for a moment and you can see his faces, and I'm going to dig into this chat box because we got a lot here. First and foremost, I want to ask Emily. So how does the data in the survey reflect any of the impact of COVID? Like what was the timing?
Yeah, that's a good question. COVID has impacted all of us, and research and our work is no exception. But actually, luckily or unluckily, about 30% of our survey responses came in during the period of COVID. That means that we fielded the survey, patients received the survey and filled it out during the impact of COVID. But we did look into that data extremely carefully because we wanted to understand if there were huge differences in scores across the board between survey responses that came in prior to COVID and survey responses that came in during COVID. And we actually found very little difference. Part of that might be that we're asking the patient to tell us about their experience of care over the prior 6 months, which a good chunk of that would fall outside of the COVID period. But really, the greatest impact we saw was maybe like a 1.2% decrease in access. It really, the scores were really not very different, which again, I was surprised by, but also very happy to see.
And a follow-up to that, I was thinking about kind of the changes in access besides increased demand since COVID, right? The greater adoption of telehealth, right? And I think behavioral health has kind of been leading the way in this already, with that expansion. Our future surveys, are there existing data sets that might help us better understand access via telehealth?
Great question. Also something we've been thinking about a ton because you have to think about it now. There's no choice. For better or for worse, care has been moving digital, and this pandemic has really made a shift that we think is likely to be relatively permanent. So what PAS has done is we've actually developed our own telehealth survey. We did a market scan of about 13 different existing telehealth patient experience surveys, and we picked the best of those and also created a lot of our own new questions. And we are piloting that actually next week. That will go out to some 13, I think, provider organizations, some of whom are probably represented on the call today, so thank you. And we're going to be using the findings from that telehealth patient experience pilot to inform our work going forward. And we're also going to be modifying our annual survey to include virtual visits. So I think the next couple of years are going to be very interesting to see how the data shifts with the move to telehealth.
Cool. I have a question from Dr. Lance Lang. So was there any way to distinguish those groups that integrated behavioral health and physical health versus those that don't have integration?
Oh, I wish we could say that. We would need to collect additional data to better understand that. We don't know from the data we have whether or not the groups had integrated behavioral health or not.
So why you didn't know specifically, I wonder, because I'm thinking about that slide that you shared, right, with the IPA versus medical group, and there was a difference in screening, but not necessarily a difference in access to care.
Yeah, that was an interesting finding. We don't know specifically if the self-identified medical groups have integrated behavioral health care. We could probably assume that they do. At least more than those patients served in an IPA setting have access to. But I think it's a really interesting finding that even if the medical groups do have integrated behavioral health care, from a patient's perspective, they're still having trouble accessing care, and the access to care at the medical groups is not much greater than at an IPA. So I think that would be a great topic for further exploration.
I'll have a lot of theories running through my head of why that could be.
Sure.
Well, no, and so right, and I love to hear people's in the chat box as well. Right, is thinking about, right, some of those like medical groups there's probably more medical groups that have integrated care. Right, they're bigger systems, centralized, centralized systems and resources that allow them to do kind of more systematic screenings. Right, I think I'm maybe stepping out of line, but that's true not just for behavioral health screening. Right, versus the access to care is even if you may not be treating them within primary care, right? If they have coverage, then they could be going elsewhere, right? Outside the system, maybe. Yeah, I'm rambling. But yeah, so this is an interesting point. I think digging a little deeper into the integrated systems versus other, and ensuring that data, figuring out how to do that. I think some of it's anecdotally. So I'll say, at CQC, we're launching a program called CalHIVE Network, but it's in kind of Southern California, a mixture of IPAs, FQs, and some medical groups. And we're gonna, at first we weren't gonna bring in depression screening, we're just gonna measure it. But now we have a request to actually build that into the curriculum. And so I'm curious to see, as participating in this program, being an advisor, to start to see some of those differences that may guide some further questions to dig deeper. Well, thank you. Okay, and then we also have, are there any insights on the percent that start treatment, that finish treatment, and percent adherence, especially on behavioral health, and especially for young versus older?
Oh man, those are such great questions, and great questions to ask in a patient survey, because those aren't always things that you can get full insight into with the existing process measures. Unfortunately, those were not questions we asked on our survey. We debated a long time, as I mentioned, I think a full year actually, working with our expert advisory committee on what was the most important to measure within the limited physical space we had on our survey. And we wanted to start out with asking about screening and access. I think there's a possibility in future surveys we could expand those questions to get at that type of information, because I think those things are really important points to measure. We don't have the data, at least through our survey.
Yeah. So I think those are some questions that maybe organizations could look at their own clinical data to start to guide some of that. hard to get to, but super insightful. I also want to highlight, so last slide, 33% screening seems likely to be a big improvement compared to say 10 years ago. And that is absolutely right. So I'm kind of digging through my own research for this around screening rates, and Moeller had a response there in the chat, but let's see, the last kind of data set, they did a national data set, and it was, I think, of provider data, and I can send this out afterwards. But it's at 1.4% screening across the United States, right? And that's very general. And this was before the guidelines went into place. But that was kind of the, I think it was probably 2014, 2013, kind of that time. And then before changes in, ACA and coverage. And then when they looked at the state data, right, the differences that they found across the nation was that the Western United States, particularly urban areas, did a better job. So not a great job, right, but did a better job. So I just know how there's been significant improvement, and they all call out, since the guidelines were in place, they're trying to get national data sets now to better understand what the impact of those guidelines had on in increasing screening, as well as expanded coverage for mental health care, may have improved the screening rates and then access to the care.
Yeah, and one thing to note that I know I've said this a couple of times, just want to reiterate that we did not send this survey to patients who were under the care of a behavioral health specialist, at least during the sampling period that we looked at. So I imagine that screening rates would probably be higher if we were including patients that were seeing a behavioral health specialist. I would really hope that that would be a standard workflow for them.
Okay, so let's dive into, I'm going to share my screen again. What can organizations do with this data?
So this is not a validated framework. This is just out of top of my own head, what I think you should do with this data. I think measurement, of course, is the basis that underlies everything you do in terms of improving. You need to interpret the data, and then you need to use the data to improve. So I'll go through a couple different scenarios on the next slide of what to think about. So if you have a feeling that your organization already collects this data, some of you might be collecting it already, and if so, that's fantastic. Then your first step would just be to understand where the data lives, who has access to it, and who can give it to you. And then once you have the data, I would really take a step back and take a look at what the data means. And I think also using our data from this research as a benchmark. Where do you fall? Are you hitting that average 33% screening rate? Are 60% of your patients able to access care? And really dig as deep as you possibly can into where your gaps are. And then, of course, once you've identified your gaps, you can work to improve them. So as Crystal mentioned, CQC will be doing some future webinars on how to actually dive in and improve your screening and access for patients. So I really get on their newsletter if you're not already. Sign up for those webinars, learn as much as you can, and then use the findings and the learnings from that webinar to create an action plan that you can work on within your organization. And then if your organization does not collect the data already, of course, in an ideal world, you could start collecting it. And I think our research questions would be a great place to start. Of course, I'm biased because we spent a full year developing them, but I think they're pretty comprehensive. So if you want to, please email me and I can send you a copy of the survey questions that you can use to field with your own patients and get your own data. And then of course, interpretation, if you don't have your own data already, use ours as a proxy. It's not perfect and it's not specific to your organization, but I think it's the best and most recent data that is publicly available. So I think it's safe to assume that your screening rates could be around 30% and 60% of your patients could be able to access mental health care. So really, take a look at what data you do have and figure out where the gaps are. And then I think the action steps are pretty much the same. Set goals. Where do you want to be? What's realistic for your organization? Learn as much as you can from the future CQC webinars, and then identify an action plan to get you closer to your goals.
Thanks, Emily. One thing that if you don't have this data already, right, I think using it as a proxy to get started and get some movement going around that improvement, and thinking about how how might you set up a measurement plan? So I go back to that kind of triangle inverted pyramid that I shared before, right, of different ways of trying to, and as Wendy and Lance pointed out, it may not give you a great sense of access, right, to care, but at least, right, but things definitely within your control of increasing those screening rates, right, that how might you within your organization with the tools that you have available, right, EHR, right, some people have centralized systems, some are, right, disparate, but collect that data on kind of connections to care and following up on the example of PHQ-9, right? Was it given? And then if positive at a certain score, right, that it's repeatedly given to kind of monitor changes in those outcomes. And so I think figuring out what works for your organization and your resources, and it can be a real challenge in this area. But it doesn't necessarily, right, the clinical number on that is assessments don't necessarily equate or are synonymous with their access to care treatment, which is a big area. So I'm noting, so Lance, so what are the best non-survey measures of behavioral health access? And I think this is a great question for anyone. So feel free, anyone, you're on the call, right? I know we have some experts here of your perspectives, and because I don't know that there's a definitive answer, right? And my sense is we're not robustly looking all over the place to have this is the one to go to. So it seems like there's a lot of room for us to really figure out how to measure this. That being said, right, we still struggle on the physical side about measures of access to physical care, right? This kind of appointment availability, which physical care you monitor within your system, but behavioral health care, because you may access care across systems, right? So kind of distinguishing between access to that care within your own system. So if you're a primary care system, treating mild to moderate, right?
I think it could also be, a good first step could also be asking your trusted physician partners and advisors, what do you do in terms of screening? And then what happens if a patient screens positive? What happens then? Do you try to handle the mild to moderate cases within your own primary care, or do you refer out? Where do you have a sense of where those patients are going? So I think probably gathering as much data as you can from different sources, I would recommend as a good best practice.
Some questions that came in through the event registration. I'm thinking about the kind of future explorations with this data. So how can value-based payment methods be leveraged to get this moving, right? I'm thinking about the note about, right, that Cover California has been interested in building this into contracts with plans to, I think at the very least, improve screening rates, right?
Yeah, I think setting guidelines is incredibly important, and also supporting groups that need a little extra help to make sure that screening is part of their standard workflow. And then I think from a payer perspective, it's really important to pay for those screenings. I think that is incredibly important because it does take time, both to have the patient fill out the survey, to enter the data, and then have a discussion with the patient about the results. I think there definitely needs to be standard payment across the payers for completing screenings.
Well, let me ask you, because in our work, right, we're both at PBGH, but you work a little more closely with the purchasers, right, the large employers purchasing care, and they've been motivated around this before COVID, but even more so, right? What's your sense of where are they going around their kind of expectations and the contracts that they put in place with plans around kind of mental health?
Yeah, I think that's a great question. We have a whole mental health work group with our employer members, and they want better for their employees and their communities at large. And it's really something that they are focusing on greatly. I would say screening and access are definitely top concerns for them. I can't say for sure how many of them are actually getting down to the granular level of putting screening into their contracts, but it's definitely something that if they're not doing already, they are thinking about. So I think it's very important for them.
Yeah, at the very least, is it, maybe they're not to the point of the screening, but asking for the data, right? I think I've heard them ask, they just want more data, more transparency about the kind of care that their patients are getting. So not on diagnoses, right? But are they getting screened? That kind of thing. Is that fair to say? Let me just check myself.
Yeah, I would.
Yeah,
So that's
one of our
definitely
data, right? And so I think it kind of circles back to that question of and how we work as a system to really come up with some really good measurements, because there's not definitive answers, particularly around access, right? We do have some really particularly HEDIS message around depression screening and follow-up, but not necessarily that fully reflects impacts we have on access to care, right?
Yeah, access is such a top concern for employers, and I'm very comfortable saying that they really are, their employees are struggling. And I mean, I think depression is the leading cause of workplace disability. So it's very important to the employers that they are addressing not only depression, but other mental health conditions that can affect their operations. It's becoming a huge issue, especially with COVID. I think employers are really realizing that they have a role to play in taking care of their employees' mental health. And that means making sure that their employees are okay, checking in with them, both from the employer perspective and also from a provider perspective, making sure someone's checking in on their patients, because we know mental health concerns are rising drastically during the pandemic. And then once someone checks in, they need access to services if they need it.
Yeah, I think it's interesting that the intersection that's coming together and right, this, as with many things, we need a systemic solution, right? And so it's not all in the provider organizations to somehow create access to all this care, right? Particularly alone. And so this system solution, and definitely I'll second Lance's solve payment gaps with population-based payment. So efforts towards that. Also, I will say, as someone who kind of lives more in the delivery system and supporting provider organizations than the necessary purchasers, of this push among purchasers to search out additional solutions for mental health. And so I think it was way back up in the chat, maybe you can put it again. Emily did this, wasn't it your MBA thesis or something, right? Yes. Of all of the digital health tools and a review of that purchasers are, employers, right, are looking at and providing to their employees. But I think this point I also on my delivery system had it was like, all of a sudden now that's outside of the system. It even adds more complexity, right? And how do we integrate that into the longitudinal care and the relationships that are happening within the delivery system too? And so, right, so lots of things happening.
there's no one pure solution. I mean, healthcare does not operate in a vacuum. It's a really community-based effort. And I think just the fact that a lot of people are accessing care through lots of different modes, whether it be through the primary care referral, or through the health plan, or through a point solution that's specific to behavioral health, the primary care provider really needs to know where the patient is getting their care so that they can monitor how they're doing. So I think it's just really important to ask the patient's perspective, because the patient is the only one who knows everything about themselves. And, a lot of these systems don't necessarily talk to each other. So the patient is the one who has all of that information. So it's really important to ask them.
Thank you. Super interesting. Okay. See, Michelle, can you, we got a few more minutes and take us through the end. So first, thank you very much, Emily, for all of your insight, the data, the partnership, and thank you to you all for the incredible questions and the feedback and data that was coming in through the chat. And so really appreciate all of that, and we will continue this conversation.
Great. Thank you, Crystal and Emily, and thank you everybody for attending. Before we go, we do have a couple of announcements. We will have our next Resilient Primary Care Series webinar, and the next series will be focusing on primary care and maternity care integration, and registration is available. And you can find that on the calquality.org page under events, but when you get these slide materials, you can access through this link right here. We will also be continuing our Accelerating Integrated Care series. And as mentioned, we'll be diving deeper into the measurement and screening tools and going further into what was discussed here. So thank you everybody for joining us.